It's not quite like that. It's more like this. We're basically placing a finger in the rectum and feeling the outside of the prostate. If there was an easier way to examine the prostate, believe me, we would do it. This is the only way really to feel it. What we're looking for and what we're feeling for is any lumps or bumps, anything suggestive of cancer, any nodules, anything like that, any asymmetry if one side's bigger than the other. Depending on what we feel, may depend on what stage you're at. So don't fear the finger, basically. Okay. So the PSA, the prostate-specific antigen, it is a protein made by prostate cells. It is very specific for the prostate, but not specific for prostate cancer, and that's where the problem comes in. There are lots of other reasons the PSA can be elevated. They all have to do with the prostate, but not necessarily prostate cancer. So prostate infection, prostate inflammation, prostate enlargement. The larger the prostate, the more prostate cells, the more PSA it's going to have. Prostate trauma, meaning the digital rectal exam, and I always tell patients, when I do my rectal exam and I want you to get your PSA, don't get it today, don't get it tomorrow, because it can falsely elevate your PSA for about 1 day or so. Ejaculation can bump it up for 2 or 3 days. So when I tell patients, go get your PSA, I always say, make sure you don't ejaculate for about 3 days prior to getting the test. So it takes some planning. Some men can't necessarily wait that long, but it's best if you do.
This test is damn useless.
Not damn useless. It's good, but it's not perfect. It's not perfect, and that's never been disputed. But it's the best thing we have, and it's a heck of a lot better than the rectal exam alone. That's for sure.
Yeah,
So
I mean,
there's plus and minuses to both sides of it.
And it's the best mower I have. But
true, and if you didn't use it, your lawn would get very, very long.
Yeah, that's why I hired somebody.
That's true.
So are you going to talk about the value range or later on?
Of what, the PSA?
Yeah.
Not specifically, I sort of gloss over it, but as far as number-wise,
Yeah.
there used to be a cutoff of 4.
Yeah, that's why now there's some argument like
Yeah.
used to be like if you more than 3 or 4, then
Yeah. So
there's a problem.
4
But now they sort of lower.
4 used to be a cutoff. Anything below 4, you're fine. Everything above 4, you're not fine.
Yeah.
It's not a one-size-fits-all, we know now, because of what we talked about before. Enlarged prostate can make it large. It will have more prostate cells, and you'll make more PSA. Plus, the older you are, likely the bigger the prostate, likely the more PSA. So now, really, what you should be doing is it's on a grading system, basically an age scale. The older you are, the higher the PSA can be, and it's okay. Okay. There are a couple different. There's not really one set scale, but they're all very similar. And just as an example, if you're in your 40s, it should be under 2.5. 50s 3.5. 60s it can go up to 4.5. 70s 6.5. So there's a sort of a gradient. It's no longer 4. It shouldn't be 4. That's sort of older data.
But do they also look at like this year maybe 1.5, then next year become 2.5?
Absolutely. We'll talk about that later, but yeah, that's another thing. And that's one of the problems with the task force I have as well, is that you can't just make a blanket statement and say you can't use it. You have to use it wisely. You don't just use the PSA and say, oh, this is your number, go biopsy. You have to look at what it does over time. You have to use what it does per year, what the rate of rise is. There's other factors like free PSA you can use. There's so many other factors besides just PSA, and you have to use it, wisely as opposed to just random number. And you repeat it. You make sure it's real. You look at it over a long period of time. That's really what you should do. How useful is this? You mentioned this. It's linear. So we have some good data that says if you combine the rectal exam with the family history, with the PSA, it is a relatively good indicator of risk. Now, again, you're still, you're dealing with 40, 60%, 70%. So is it a perfect test? Absolutely not. It's the best test we have, and it's good, but it's not perfect. But it gives you some good data. It gives you some sort of as a good initial kind of screening test. Treatments, I'm just going to sort of briefly gloss over. It can be mind-numbing when you're first diagnosed with prostate cancer. This is quite a blow psychologically and in every other way. Active surveillance is becoming much more common these days and much more accepted. It used to be unheard of to do this, where basically you don't do anything treatment-wise, but you watch it closely, repeat the biopsy, keep a close eye on the PSA and the rectal exam, and then at some point, if you get scared or the patient gets scared or you see a rise in PSA or something changes, then you go ahead and treat. Over the last 5 to 10 years, it is becoming much more common, probably 5 years, it's becoming much more common, because we know that in general, men aren't dying of this disease, so it's much more common to do sort of active surveillance. Radical prostatectomy, removing the prostate. There's several ways you can radiate. Cryotherapy is freezing the prostate. Proton beam is relatively new, and only in certain areas of the country. And then HIFU is listed at the bottom. I'm just going to talk for 20 seconds about HIFU because patients, a lot of people don't even know what it is. It's sort of near and dear to my heart because I think it's fascinating, and I think there may be a future in it. I'm one of 5 urologists that I know from Northern Virginia to Baltimore that has been trained to do this. It's using ultrasound beams to treat the prostate. So we're focusing ultrasound waves, safe ultrasound waves that we use every day on babies and pregnant women, and we focus those beams at a certain point. And at that point, it creates enough energy to go to 90 to 100 degrees Celsius and kill whatever cells are in the path. It's very similar, and I use the analogy, it's like using a magnifying glass to burn a leaf. So if you hold that leaf far away, nothing happens. If you hold that leaf close, nothing happens. But right at that sweet spot, right at that focal point, you create fire. It's the same thing with the ultrasound beams. All the tissue farther away are unharmed. All the tissue close by are unharmed. But at that focal point, you kill any cells that's there. You can do that wherever you want.
Yeah.
The nice thing is you don't really burn any bridges. You can always, if it does fail, you can always repeat it or go on to surgery or radiation. The downside of it is it has not been around very long, so we don't know the good long-term data on it. But I just wanted to mention it because not a lot of people know about it, and I think it's something that potentially has some usefulness in the future. It may be widely used.
Can you accurately locate the point so using each beam?
You're doing this sort of on real time. You're using a computer in real-time imaging on ultrasound. So you're looking at the prostate, you're basically making a map and saying, okay, on the computer, this is where I want to go. I'm just basically going all around the prostate. And it has relatively good sort of pinpoint accuracy, so you don't spread outside the prostate. You can if you want to, but you can sort of limit it right to the prostate.
So you're using image to determine the location?
Absolutely, yeah.
Simultaneously?
Real
And
time.
it's really just heat that's doing it.
Yeah, heat killing cells. So it's fascinating stuff. It is not FDA approved yet, so we actually have to travel outside the U.S. to do it, but hopefully they're hoping by spring of 2013 that it will be approved. So,
You mean you've got studies underway?
Yeah, there are studies underway. They're ending the studies. They're almost done with accrual and ending the studies, but it's been going on for a couple of years. So they do have some good data, and I think the FDA is starting to look at some of the finished data. I'm not exactly sure, but they're hoping by spring of 2013 that it may get approved. So we'll see.
So you say you were one of the 5?
I know of 5 of, I'm one of the 5 that I know of.
So you went outside for training? Outside USA?
Bermuda is the closest site, and the Bahamas is the other closest site.
Oh, I volunteer for the
I'm
Bahamas.
sure. Making a vacation. When I was training, they said people actually make a vacation. I said, you gotta be kidding me. But people do. They go down a week early or stay a week late and bring their family. It's interesting. So treatment-wise, there is no perfect treatment. Each has sort of advantages and disadvantages, and all of them have potential life-changing side effects, including erectile dysfunction, incontinence, potential for other cancers or strictures, that sort of thing. So yeah, obviously it's not without some downside to it. There is no perfect treatment. We wish there was, and really the perfect one is a good balance between cure and side effects, or cure and complication rate. And there is no perfect one. Not yet, at least. This is just a funny picture I saw on the internet.
It's like a parking lot at Sherwood High School.
At a certain time a day, this London's Westminster Bridge. There was some talk whether this was photoshopped or not, but I thought it was funny anyway. So.